Okay, we're going to go ahead and get started. Good morning, everyone. Can everyone hear me okay? Terrific, great. I'm Lisa Prosser, Associate Vice President for Health Sciences Research here at the University of Michigan, and really delighted to join you all today so that together we can embark on a critical conversation about one of the greatest challenges impacting communities nationwide and here in Michigan. Every day across the United States, about 200 people die as the result of opioid overdose. The opioid epidemic is the single deadliest drug epidemic in our nation's history. Unfortunately, this crisis continues to grow more intense every year. In order to mitigate harm and reduce deaths, we must support and catalyze new and innovative opioid research. We must also strengthen research collaborations between academia, government, and industry. This will be part of the conversation today. Due to its complexity, this crisis requires a multifaceted approach, and this is where the University of Michigan plays a critical role. As one of the nation's leading public research universities, U of M is uniquely positioned to address this crisis and support groups that are seeking solutions. Last month, U of M launched its new Opioid Research Institute. This institute symbolizes our commitment to expanding support, services, and strategies to individuals, families, and communities that are working to combat the opioid crisis. It also symbolizes the university's longstanding commitment to truly interdisciplinary research, as this institute brings together faculty and collaborators from across multiple schools and colleges. By bringing together experts and external partners, the institute can catalyze and expand high-impact research, programs, and collaborations that address opioid misuse treatment and prevention. Also last month, in partnership with the Michigan Department of Health and Human Services, Wayne State, and Michigan State, U of M launched a new technical assistance collaborative. This collaborative is designed to support local governments across Michigan so they can develop effective abatement strategies to address the ongoing opioid epidemic, and you'll be hearing more about that today. Our guests today, who you'll hear from shortly, share our commitment to tackling the opioid crisis with evidence-based, high-impact programs and strategies. I'm grateful to our keynote speaker, Dr. Keith Humphreys, for joining us here today, as well as our inaugural Institute co-directors, Amy Bonnert and Chad Brummett, for participating in today's critical conversation and for their continued efforts in this space. I also encourage everyone here in attendance to remain engaged in this important work. And I would like to turn things over and look forward to the conversation today. I'll turn things over to Dr. Amy Bonnert.
Good morning, and thank you so much for being here today. Unfortunately, the Attorney General who was planning to be here today had an urgent matter come up and was unable to join us. She sends her sincere apologies and hopes to make it to campus soon to discuss these very topics with us. I am Amy Bonnert. I'm a professor of anesthesiology and as Lisa, as Lisa mentioned, one of the co-directors of the U of M Opioid Research Institute. It's encouraging to see you here today in person and virtually to discuss a critical component of addressing the opioid epidemic, which is how academic and government institutions can best work together to provide communities with evidence-based strategies to save lives. Our guest faculty speaker, Dr. Keith Humphreys, has an extensive background in making these connections and creating these collaborative networks. As the Esther Ting Memorial Professor in the Department of Psychiatry and Behavioral Sciences at Stanford University, Dr. Humphreys' research addresses addictive disorders and translation to science of public policy. He has been extensively involved in the formation of national and state public policy, having served on the White House Commission on Drug-Free Communities during the Bush administration, as well as senior policy advisor to the White House Office of National Drug Control Policy under President Obama. Dr. Humphreys also created and co-directs the Stanford Network on Addiction Policy, which brings together scientists and policymakers to improve public policies regarding addictive substances. He also leads the Stanford Lancet Commission on the North American Opioid Crisis, on which he kindly invited me to serve. Today, Dr. Humphreys will discuss approaches to the North American opioid crisis, share some of his findings around state and federal response, and challenge attendees to think about innovative solutions to this ongoing epidemic. With that, please join me in welcoming my friend and esteemed colleague, Dr. Keith Humphreys, to the University of Michigan.
Thanks for coming, everybody. Really good to be here. back. I actually went to school at Michigan State down the street, and it's exciting to be back. And I never disliked U of M. I just want to make that clear. So I've always admired this university, and it's wonderful to visit. I want to start by thanking Dr. Brummett for being one of my co-hosts, and I want to thank Amy, Dr. Boner, twice, because not only is she one of my co-hosts, but she is on the commission that I'm going to present the results of today, and was a very valuable member of it indeed. And you are fortunate and wise that you've launched this new initiative and that you have Dr. Bonnet and Dr. Brummett to run it. I just think it's really exciting, particularly with the money coming from the lawsuits. It's a really good time to have science injected into the policy discussion. So it's a really great foresight of U of M to get that going. So this talk is, these commissions are very long. They're almost like a small book. And if I talked through all of it, it would go on and be, I think, probably a little hard just to sit through such a long talk. So what I'm going to do is I'm going to pause at specific points and give you a chance to ask questions, so you don't have to hold everything to the end. So you'll get to have some input as we go. So we got that going? We do. Awesome. One of the problems in this area is that there's been a lot of undisclosed conflicts of interest by people who speak about opioids without admitting financial connections. So let me model the behavior we recommend everyone use in this area, which is to tell you I personally have never had any financial connection with the opioid industry or with opiate manufacturers, nor have I ever testified in a lawsuit against the industry either. And I was fortunate in this case that my medical school was willing to give an unrestricted philanthropic grant to support the commission's work. So we could say whatever we wanted to say, and as you will see, we did. The commissioners very kindly donated their time and worked for 18 months, which is a long commitment, to get to a point of agreement. But what we concluded you should think of as those are the commission's conclusions. They are not Stanford conclusions, they're not VA conclusions, nor are they the conclusions of the Lancet or any of the commissioners. Details on everyone's disclosures, you can see there's a website, opioids.stanford.edu. It's all there, exhaustively laid out. If you want to look at it, you can. In case you wonder how this all works, so Lancet came to me and said, would you want to do this? And I went to my institution and said, would you co-sponsor it? And they agreed that they would. We got 17 really talented people from the United States and Canada, which were the nations we were focused on. About half of them, roughly, or a little more than half, were at Stanford. And it was a really diverse group. So we had people, as you would expect, with background in addiction medicine. We were always lucky we had Amy and other people with backgrounds in epidemiology, but also economics, law, policy analysis, public health, and pain medicine as well, which is a very important aspect of this. And people were different in their roles. There were people who were mainly clinical, people who were researchers, people who were teachers, and we also had people who had experienced addiction and people who had experienced chronic pain. Here's who the members are. Some of these are friends of mine from the Obama administration. You may know some of them. Howard Coase, I think pretty well known. Tino Cuellar, mostly academics, but all just really did superb work. We're also indebted. We have a superb advisory committee, which was Richard Frank, Ann Case, and Shelley Greenberg. And I also want to acknowledge Tom Coderre, who started on our commission, and then the president stole him from us. He went in around SAMHSA, so that was smart of them to get him. But we were grateful, at least, his participation in the initial discussions. So where are we right now? We're not in a good place. Here's the situation. We think about this in terms of waves. There were 3 waves. The first wave starts in the mid to late 90s, when opioid prescribing started to go up very fast. And by fast, I mean it eventually quadrupled over about 11 or 12 years, quadrupled per capita, to the point that in 2010, we had 250 million opioid prescriptions, and we have 250 million adults, just to give you a sense of how much was prescribed. Now, some of that prescribing was appropriate, and it helped people in pain, but there were also a lot of costs, which was more and more people getting addicted to these medications and overdosing on them. And you can see that on the left. These are deaths from different types of opioids, but the first wave was pills. Then around 2010, heroin markets revived. The reason that happened was that you had essentially demand created by people who were addicted to pills, and criminals realized they could convert those people over, like because OxyContin would trade for about 3 times what heroin would. And we'd always had heroin, of course, in the United States, or at least since the 60s and 70s, but not in a lot of places we got it. So we had heroin markets in Philadelphia and New York and Los Angeles, but we started to get heroin markets in places like Youngstown, Ohio, and Steubenville, and certainly in many towns in Michigan that hadn't had it. And so that caused another wave of deaths, making things worse, and people were dying from heroin. And then in 2014 or so, then things go from terrible to even more so, which is with the arrival of fentanyl, which I think everyone knows is a synthetic, extremely potent opioid. That entered the supply as well, and now we're having an extraordinary number of deaths from fentanyl. Probably this year it'll be about 75,000 people lose their life just to that one opioid. At the same time, you shouldn't think, I guess those previous waves are over. No, there's still people dying from heroin. There's still people dying from OxyContin. It's just one wave is hit on top of the other. And it's in many people's story, when you read and you say that's a fentanyl overdose, when you read their life story, it may be, they used heroin for many years before that, or maybe they initially started with pills. So they're all still connected. You shouldn't think that the past is gone. It's still very much with us. How much mortality is there? This is really kind of shocking. This is a map of the US and Canada. I'm sad to say my home state of West Virginia is the darkest. We have the highest death rate. But it's not low anywhere. And you can see the particularly hard hit areas. British Columbia is the hardest hit in Canada. Appalachia, hardest hit in the United States. If you want an anchor point, if you're about my age, you certainly remember HIV/AIDS, and how terrifying and awful that was. In the very worst year, the deaths from HIV/AIDS were, you'd have to go half again as much to get to where we are now with opioids. So this is the worst public health crisis of my lifetime and probably your lifetime too. It hasn't hit groups equally or at the same time. The forgotten group are indigenous peoples. They get hardly any attention at all, but the whole way through, people have suffered. Native Americans have suffered, as bad as anybody. It's hardly ever in the paper, but it's something that really weighs on me and weighs on those communities. Also, at the beginning, I think much better publicized, there were a lot of white people, like from places like West Virginia, up in New England, and so on, and they were dying. As fentanyl has arrived, things have shifted. So they've had very fast increase in deaths among African Americans, pretty fast among Hispanics or Latinos, coming closer together. So right now, the black rate and the white rate are very similar. And all through that, again, Native Americans are having the hardest time. Our model is, this was led by Isabel Rao, who's a brilliant, just got her doctorate at Stanford. She was a graduate student when she did this work. But this is really sobering. We predict over this decade that over 1 million people will die of overdoses if we don't change our policy framework. And when that first came out of the model, I thought, gosh, that seems awfully high. That's like 100,000 people a year. That couldn't possibly happen. And then now I'm afraid maybe we were a bit conservative because, of course, we lost over 100,000 people to drug overdose last year. Why did this happen? So obviously, we had a lot of appalling behavior by manufacturers and distributors of opioids. Companies you all have heard of, the Sackler family, Purdue Pharma, also other companies that for some reason aren't, it's not attributed as much to them, but groups, like Mallinckrodt, like Johnson & Johnson, like Teva. And then the distributors, companies like Cardinal Health, for example, that shipped enormous numbers of opioids to small towns and should have been suspicious of those shipments, but kept making them anyway because it was all very lucrative. So they deserve blame. They are thought of as villains, and they were. But it would be a mistake to think that this was like, if you saw the Lord of the Rings movie, The Two Towers, remember the orcs take over Helm's Deep. And you're just amazed, like, wow, you really need a massive army to overcome such high walls and such noble defenders. That is not the situation. It's much more the walls were made of Swiss cheese, and half the people who should have been protecting them were sleeping, and some of them were working with the orcs. There were terrible failures in regulation, failures by Congress, failures by federal agencies, failures by medical schools, failures by boards of pharmacy, failures in law that made this possible. And the reason it's important to understand that and not think somehow these crafty companies overcame a really strong system is all of this could happen again. If we don't fix these problems, this could happen with benzodiazepines. It could happen, we've just approved esketamine. Maybe someday we're going to approve MDMA. There's no reason you couldn't do this all over again. So that's why you have to fix the holes that those companies exploited. It's clear also that this was a case where illicit markets and licit markets actually work together, which is against traditional economic theory. Normally you think if something's legalized, then black markets in it shrink. Because why would people go to a criminal when they could get a legal market? But in this case, the expansion of the legal market actually grew an illicit market. And that's important if you're understanding, again, responsibility. Sometimes the companies say, you can't blame us that anyone's using heroin. We don't make heroin. Or you can't blame us that anyone's using fentanyl. That's literally true, but on the other hand, where did all those dealers come from? They originally came to service people who were addicted to pharmaceuticals. So they actually do bear, in my opinion, responsibility. And last, this will surprise nobody, COVID made this much, much worse. you almost couldn't have a worse endemic than these two things. So, what did COVID do on the negative side? Isolation, loss, depression, fear, anxiety, and on the structural side, less accountability, less social contact, less sort of rhythm to life. So those two things together, essentially reasons to use a substance and the things that might protect you, keep you in recovery, or help you use less, were both altered. And that's why we saw just terrible. The worst increase in overdoses in my life was the first year of COVID. Most cities were up like 30, 40, 50%. Canada went up, I think, 65 or 70% first year of COVID. So that's made things worse. And the upside to that is as COVID, knock on wood, is waning a bit, that should help us a bit with this problem. Now, these, don't be intimidated by the slide. I'm not going to talk for 3 hours, although I probably could. But we've got 7 domains that we addressed. We had lots of recommendations in them. I'm only going to give you some of them, just so we can have a sort of discussable chunk of information. We had a rule that you had to have 90% agreement to have a recommendation in the commission. And you might think, well, we wouldn't be able to agree on anything because we're academics, but nonetheless, we did. There was really a lot of work. Some ideas just didn't carry. Some even only had a few objectors. We dropped those out. These are things everybody thought made sense. And they're in 7 different domains. So the first one is looking at this as a failure in multi-system regulation. Second, to understand that opioids are not bad. They are, in fact, very good when used properly, but they have risks. And to not get stuck in the idea of we need to get rid of them, we need to have unlimited or none, but try to find a balance. Third, about the care of people with substance use disorders. Fourth, about what is the criminal justice system's role in all this, if any. Fifth was what about prevention? What about healthy environments, particularly for young people? Sixth, how do we stimulate innovation in response to addiction? And then last, how do we stop this from happening in other countries? So let's start with the multi-system regulatory failure. This, to me, still shocks as a slide. So this is UN data, which is standard daily doses per million, and it's population adjusted. And these are only, in the slide, wealthy countries. So these are countries, the poor countries have virtually no opioids, and that's a problem in itself. But if you just look, you compare us, we are so far out of whack. This is at the peak, around 2010. 10 times what good European healthcare systems were doing, for example. The only nation that came close to us was Canada, which of course also has an opioid crisis. Now some people look at this and they say, well, it must be pain. It must be Americans are in more pain than any other country. Not true. First off, we have a younger population than most of these other countries. But we do have pain surveys, and the 2 nations that are closest to us are these 2, Italy and France. People there are about as likely to report pain, and we're 6 and 8 times them, respectively. Again, this is at the peak. So that's not what was driving it. Of course, there's plenty of pain. One of the things that's really tragic is this was done in part by people really trying to help people in pain, and it didn't help. We still do a bad job managing pain. But that's not why this happened. It happened because it was, pressured to happen, and here's part of the economics of it. So this image is of 10 big pharmaceutical companies. You will know all these names. The orange circle, this is in billions of dollars. The orange is how much do they spend promoting their products, marketing, all those visits they make to the doctor's offices, the conferences, and so on, advertising. And then the sort of teal circle is how much they spend on research and development. So first what you'll notice is that pharma companies spend a lot more money pushing products than they do developing them. The second thing is, just for comparison, in the year this slide was made, the FDA's entire budget was $4.5 billion. Now that was to do everything the FDA does, not just monitor opioids, but they do have the food safety, the clinical trials, all kinds of things. So even just the advertising budget of the number 10 company is bigger than the entire budget of the agency that's supposed to oversee all this. So it's not surprising that we ended up where we did. And by the way, marketing really works. One thing that it's interesting, the Sacklers really pioneered this, defending marketing by saying doctors are not influenced by marketing. They just want the best for their patients. And doctors often believe this, which makes them very easy marks for people if they believe they can't be influenced. But we know this for a fact. First off, they do it because they make money. They get data. They can see if we visit doctors, their prescribing goes up. But second, as we cited in the commission report, we know like at the counties where they spent the most money on marketing, there were more deaths. And there were even a couple states, because they had triplicate prescriptions, that Purdue didn't market in at all. And those states did not have anywhere near the opioid problem as other parts of the country did. Some people think incorrectly that you could predict where overdoses are by looking at economic indicators, like where people were poor. But that actually doesn't do it. If you were poor, but you happened to be in a state with no marketing and no pills, you actually tended to do pretty well. Where it happened were the places that really got just very intense marketing and promotion of opioids. Here's a disturbing a slide about our political system. This is from the Associated Press and the Center on Public Integrity. And they studied state legislators, lobbying and campaign spending. The red in the circle is what the pharmaceutical industry spends. This is everything, not just opioids, but everything. And the orange slice that you can barely see is what people who were opposing the opioid manufacturers, these were like parents groups, things like that. It's 880 versus 4, or 220 to 1. Even if you make a really conservative assumption that only, which would be ridiculous, say if only 10% of the pharmaceutical lobbying is spent regarding opioids, you would realize this is a complete mismatch. And this certainly matters. States are hugely important in the practice of healthcare. And they bought a lot of influence and it worked for them. We also had problems with what are sometimes called astroturf groups, which means fake grassroots. The tobacco industry pioneered this with smokers' rights groups, who would show up at hearings. I'm just an ordinary citizen and I just want to say I love Marlboro's products. They're great people. And I've come to that conclusion freely and independently. So we had that a lot in this domain with groups representing patients who said they were the independent voice of patients, to quote what the American Pain Foundation said, but they were creatures of the industry. APF actually had to close down because the Senate did an investigation and found their budget, I think it was 88% of their entire budget was given to them by the pharmaceutical companies. And there's some amazing releases in some of the lawsuits now where you can see the emails of executives saying to these groups, we're on your board and we will tell you what your independent views are. We're paying the bills. And some of the people didn't even realize, like they thought it was a genuine grassroots group, but it wasn't. And this still happens. By the way, it doesn't just happen in this domain, but it's a general problem of, there are real grassroots groups for sure, but there's also a lot of fake ones. So what should be done about this? We have a lot of recommendations, but here are some of the big ones. To really curtail pharmaceutical product promotion. There are countries where they just don't do that. Like in Germany, a doctor cannot accept anything that could influence prescribing or anything that looks like it might influence prescribing, even just looks like it. And they can't accept anything not just that is to affect future prescribing, but also anything that could be construed as a reward for prior prescribing. We could just make this illegal and have to have those wonderful, charming, well-dressed people running into all these offices getting doctors to prescribe everything. There would be, could be challenges to that on free speech grounds. We have a particular way of handling speech that is different from other countries. That's why we have ads on TV with the pills on them, and hardly any other place on earth does. Another way to do it, which has been introduced by Senator Jean Shaheen of New Hampshire, would be to remove the tax deductibility of promotion of addictive drugs. And so one of the things that really makes me mad, and I hope makes you mad, is all this marketing. Don't forget, you helped pay for it because it was tax deductible. So if you changed the incentives financially so that companies weren't subsidized through a tax deduction to do all this promotion, maybe they would do less. We need to do something about the revolving door between industry and regulators. And the best example of this comes from the approval of OxyContin, which had a label on it that was later held in court to be fraudulent that said this is believed to be less addictive than other opioids. Now the person who approved that label at FDA and approved OxyContin, 12 months later was working where? Purdue Pharma for triple the salary he made at the FDA. Now, there is a place and a time for some exchange of staff between industry and regulatory bodies, but at this point, you only have to be off for 12 months. You can go work for people whose financial livelihood depended on your decisions. Those things need to be changed. We saw similar things happen when the DEA tried to stop distributors from shipping enormous quantities of pills to small towns in places like West Virginia. And essentially, the industry hired away a lot of DEA lawyers and attorneys and chemists who then turned against them, and they rolled to Congress, and Congress took away those powers from the DEA. And so we need to have some restrictions there. We also need to pay really good civil servants more. If we have someone who's outstanding at evaluating products, that person has great value to the public. Why not give them a good salary? That's one reason why people leave the public service. We also think we should expose these fraudulent astroturf groups, and there actually is a Deceptive Practices Act where we could do that. For example, right now, it's illegal to hire someone to write Amazon reviews about how great your book is, because that's considered a fraud on the public and also fraud on the investor in the publisher, that law could be extended to say you cannot covertly fund a grassroots group. That is fraud. And you're making it look like the market for your products is bigger than it is. We could also require an SEC filing as corporations to reveal what independent grassroots groups do you fund. And then last, I know this won't happen, we all know this won't happen, but we think it was worth saying that we have removed all limits on what can be given to candidates for office in the United States. That is a part of the problem. I mean, when you can write that big checks, that's going to affect the political process and not in a good way. So just as a point of principle, we said that's something that's not going to change in our lifetime, but it really ought to. So this is one of our designated pauses. And just ask if you have any questions just about what I've talked about, which is the status of the opioid crisis and the sort of regulatory failures that we had. Going once? Yeah, go ahead.
Hopefully it's not too far off topic. One of the things you kind of said was one of the driving factors was sort of marketing.
Mm-hmm.
Not so much necessarily socioeconomic. And to see though, is there any evidence there's sort of a potentiating effect that?
Yeah. So let me repeat the question so everyone can hear it. So I said, marketing was a really good predictor, and socioeconomic status was not. But you could ask a different question, which it is, let's say a community was poor, distressed, and unhappy, and it got hit by marketing. I think that's entirely plausible that drugs would catch fire there faster than they would in a community where there were lots of other rewards. And I'm going to get into that a bit later about reward in general in the eyes of a brain is always a relative judgment. What other things are there to do and how rewarding are they? So thank you, it's a good question. Was there another comment? I thought I maybe saw somebody. Yeah. Okay, well, I promise there'll be other pauses where you can add your ideas, and I do really want to hear them. So now let's talk about opioids as a dual nature, as a benefit and risk for health. This is very, very hard for people. There's a whole literature on affective influences on judgment, and to just summarize it really quickly, human beings like to say things are good and bad, or bad, excuse me. They do not like to hear that something is good and bad, and that it's a mix, and it's got some good stuff and some bad stuff. And we've seen a lot of that dynamic in place throughout the opioid crisis. And it's understandable, too, this is a very emotional issue. People are dying, people are getting addicted, people are being denied pain medication they need. So it gets very ramped up. But we really tried hard to just say, these are just molecules. They have no moral meaning in themselves. It's all about how you use them. Let me just try to illustrate that. So this is a book. I don't like the title, but I really like the book. It's by Mike Stein, who's a remarkable person. He's an internist and a really accomplished researcher at Brown. He also somehow manages to write novels and books about medicine. And this is a patient he calls Lucy, it's not her real name, of course, who's having to take like 40 Vicodin a day. She has to take so many pills, she's afraid to get on a flight because she's afraid she won't have a place to covertly be able to take all the pills she has to, even like an hour-long commuter flight. And she says to Michael, I don't remember what normal looks like. What you feel every day, I feel only when I take my pills. And that is a good description of how horrible it is to be addicted to prescription opioids. And we focus on deaths, of course, it's terrible. We can't forget, there's also tons of people who are not going to overdose, but their lives are really hard because they're addicted. Here's a quote by a different patient. This is a patient I took care of. I worked in hospice care for about 10 years. And this man said to me, the most terrible thing about my cancer is not my coming death. It is the memory of my grandfather in the hospital screaming for God to kill him because he was in so much pain. It was really nice for me to say to this man, we have pain medicine doctors on the hospice team, and they can do things that just weren't available when your grandfather was alive. That's not going to happen to you. And guess what? One of them is fentanyl. Fentanyl is terrible out there in the streets and people are dying, but man, it's really useful in like the care of cancer. It's a lucky thing we've had. If you've had surgery in your lifetime, you've probably had fentanyl. It's a terrific opioid when used right. And which one of these things is true? They're both true. And so you have to think that way about this. It's not like, if you've ever been to like a train at the points, and there's like a big switch, and the whole train's coming. If you put the switch that way, the whole train goes that way. You put the switch this way, the train goes that way. That is not the way to think. We need to think about this as a dial, and there's a good number somewhere in there. And if you turn it too far one way, people in pain don't get the medication they need. Turn it too far the other way, then people start getting addicted and dying. It's an imperfect process, but we just have to struggle with that. So how do you do that? One of the things we said, and this is something disappointing to me, is we need to reinvigorate the national pain strategy. We actually had a very well-developed strategy for pain with huge input from every stakeholder you could want that went from prevention to management to treatment to recovery to medication strategy to physical therapy, workforce, all that stuff. It was released at the very end of the Obama administration, and the next administration had no interest in it and just dropped it. So we call on the Biden administration, please pick this back up. Just as we need a national strategy for opioids, we need a national strategy for pain. There are a lot of people in excruciating pain. We need to restore trust in medicine. One of the things that was damaged, it's not just damage to health that the opioid crisis has caused, but it damaged trust, where people were harmed by things their doctors did, and also when, for example, doctors were hauled off for fraud or for taking covert payments. That's very bad. And if you take care of patients, trust is a very precious commodity with patients. You need trust to help people. And we say, how can medicine get that back? And we would say, to be leaders in safe prescribing initiatives. And some doctors are already doing that. You have Chad here is one of those doctors doing that. But there's other parts of the country where doctors have just, dug in their heels and say, I do not want to be monitored. There's nothing wrong with my practice. That's not the way to restore trust. The way to do it is to say, okay, we screwed up. Let's do better, and I'm going to lead that process rather than resist that process. And last, you have to remember, opioids are very useful in the treatment of opioid use disorder. And we say, and this actually has happened, that opioid agonist therapy with reasonable control should be made more available. And at the time we were writing, COVID was in effect, and there were some expansions in how you could prescribe it. And we say, we have to evaluate, make sure that nothing bad happens, but we should consider keeping these after the epidemic. And I think we will end up doing that. We also need to change how we evaluate drugs. So the way FDA thinks about a drug when it's sent in is they say, is this safe and effective if the patient takes it exactly as they're supposed to and nobody else touches it? That's how they evaluate it. But for addictive drugs, that's not a reasonable framework because there's a couple other things that happen. First off, people don't often take them as directed. Sometimes they take the whole thing in a day. That needs to be considered in the approval process. But also, other people can be harmed. So one of the things we saw over and over again is people getting addicted to opioids that were prescribed to someone else in the same household. So we say FDA has to broaden the way they think. They have to think basically like public health people, not just as in the sort of narrow clinical medicine people. And very happy to say this has been taken on. FDA put out a draft. It was very governmental, like draft, not our position, but here's what we might be saying, but don't yell at us and all that kind of stuff. But they're making those moves, which is really good. And the previous administration actually, the director there, I thought, did a nice job pushing that way. And I was really happy to see this came out shortly after, actually, right when we were doing the copy editing in our piece. This is by two former, Josh and Peter were one of the leadership of FDA when I was in the Obama administration. And they put out basically endorsing this same idea, to broaden the perspective and how we think about the approval of drugs to include public health considerations. Okay, what about substance use disorder care? We have, no matter what we do, we have a huge number of people who are suffering from what is sort of commonly called addiction, what we call in medicine substance use disorder. What are we going to do about it? Well, it starts with thinking about where did addiction treatment come from? It's not pediatrics, it's not geriatrics, which were born in the house of medicine, invented by doctors within the healthcare system, and therefore smoothly integrated in it. The addiction care system in the United States has three parents, and they are the criminal justice system, the social welfare system like Salvation Army, and the mutual help fellowships. That's where it came from, if you go back in the history. Now, all those organizations, all three, saved for sure lives, did some good work, but they aren't healthcare. And we still are kind of in that role of being the country cousin who was not, native to the system and is outside it and is stigmatized, has less workforce, less resources, and is really poorly integrated. That fundamental problem is really critical why we fail to give people good addiction care. And we say we've got to bite the bullet as a country and just say we've got to bring addiction in permanently. This is different than what we have been doing. Congress will give like a 2-year grant to states, say, this is for opioids. But notice they never do that for cancer. Wouldn't that be very strange? I think cancer is bad, but I think we can clear it up in 24 months. Here's a grant. So we'll work our way through this crisis and everything will be back to normal. No, we just assume, well, there's always going to be people with cancer. We have to have Medicare, Medicaid, VA, military health all need to cover it. Blue Cross, Blue Shield need to cover it, and it's just part of the budget. We need to get to that point with addiction where we don't see this as a short-term crisis. Because guess what? Let's say opioids disappeared tomorrow. We were losing over 100,000 people a year to alcohol. We lose people to cocaine, methamphetamine. In 10 years from now, it'll be some other drug. So we have to have the system set up to take care of that. Second, we need to get better care. This is one of the most painful things if you work in this business is, families coax and plead for someone they love to go to treatment, and then when they go to treatment and the treatment isn't any good. It's totally dispiriting for everybody and literally sometimes kills people. This is a disturbing, important study which looks at residential addiction treatment programs. It's a secret shopper study where people called up and asked about treatment. First of all, they found a huge number of treatment programs don't give medications, are hostile to evidence, sometimes force people off their medications, and the likelihood of being accredited by accreditors like the Joint Commission is totally independent of how crappy the program is. That's really bad as a quality problem. So this is something we need to, Richard Franks just used, let's just stop buying this crap. Okay, let's just get payers to say, if you offer really awful treatment, we just will not give you a penny of our money. That would be very good. But also I think moving addiction care into mainstream medicine would also help because there's much stronger quality mechanisms inside healthcare than there are in this sort of frail system that exists outside healthcare. I think I said these things. So there's a lot of work. I have to give Christina Andrews, who was one of our commissioners, great credit. She wrote really, really detailed, helpful stuff about how Medicaid works, how it works both when it works as a public system or when it's contracted and what states should do. It's all in there in great detail, really nice stuff. And also on the private side, we actually have good regulations to make insurers pay for addiction treatment, but they have to be enforced consistently. There's been some progress on that, thankfully, lately. Okay. And in terms of what services, we also had the model. This was Isabel Rao's model, Isabel and Margaret Brandow, who was on our commission. And there were 4 things that we modeled a bunch of different policies that came out very, very well. There were other policies on the control side that were good, but the number one thing was naloxone distribution. Naloxone is, if you're not an opioid person, you may not know, it's an antagonist, so it will knock the opioid out of the receptor, restart someone's breathing, and it over. It's really miraculous, actually, that we have this, thank God. That comes out as very life-saving, but also pharmacotherapies. We've got multiple. We've got methadone, we have buprenorphine, we have naltrexone. And behavioral therapies also people can benefit from. And then syringe exchange, it doesn't matter a lot because of the separation of HIV and more people smoking and all that, but it matters some. So those are services that we said, our model said should be priorities in terms of life-saving. I can say though, and this is sort of depressing, that even when we modeled everyone doing everything right, there's still going to be a lot of people dying. I hate to say that, but it is true. But we can at least make it a lot fewer, even though we can't make a perfect world. Okay, I'm paused there. I just talked about opioids and keeping the balance and about substance use disorder care. Anyone have any questions about that or any comments they'd like to make? There's one right there.
Hi, my name is Andrew. I'm a social worker. I also supervise a large needle exchange program here in Southeast Michigan, and I wanted to talk about or ask about 2 things. One, is there any movement on either the state or federal level to reduce the barriers to methadone care? Currently, to access methadone, if any of you have ever had to access methadone, you have to go to a clinic 6 days a week. The times are 6 a.m. to 11 a.m., and if you miss your dose, you don't get your methadone for the day. And then additionally, on top of that, to access buprenorphine, we are often, because I run a clinic accessing buprenorphine, we are often calling up to 20 pharmacies for one person to find that medication. And so I didn't know if there was any movement on the state or federal level to reduce those barriers. And then additionally, you highlight syringe exchange. I do want to clarify syringe exchange programs, although started initially in HIV care, and we still are predominantly focused on HIV and hepatitis C care. Syringe exchange programs traditionally have the highest rates of naloxone distribution. So for example, our program last year distributed 10,000 Narcan kits directly to the Metro Detroit area with a 2,500 overdose reversals through that program directly. So just always highlighting syringe exchange programs are on the front lines always of our current opioid crisis. So, but yeah, I just don't know if you had any kind of data on reducing barriers to methadone.
Okay, yes. So first I want to say thanks for saving lives. That's terrific. Really great to hear. Let's talk about that and also reducing barriers to naloxone, because I think have some good news on both fronts. So during COVID, the rules for telehealth were greatly relaxed, as you know, I assume, since you're involved in the care, and where you don't have to come in that much, or some cases you don't even have to come in at all. You can do it over telehealth. You can do longer take-homes. Also, there's some legislative moves to do some other things, like move methadone into pharmacies, let people take it, potentially take it in the pharmacy. That's what the British do, by the way. You don't have to go back to the clinic, and you can have more take-homes. So all that's in play. And there's the usual arguments, now COVID's over, and so DA is proposing to reinstate some of those controls, and there's been a lot of pushback. Something will come out, but we will have a more accessible system in the end. I'm quite confident of that. And then the naloxone, just last week, we got an over-the-counter naloxone product, and another one right after that. It's too expensive right now, but if we get a couple more in there, there should be some price competition and make that more accessible. And then as an over-the-counter thing, a person wouldn't have to walk up and talk to the pharmacist, which is what you have to do now. And as you know, because you work with people who use drugs, a lot of people do not want to do that. So they should be able to buy it like you could buy an aspirin. Plus, you can sell over-the-counter drugs anywhere. You could sell naloxone in a gas station. You could sell naloxone in a supermarket that didn't have a pharmacy. So that's all good. I think those are signs of hope in a time of bleakness. So, any other comments? Yeah, there's one.
Really appreciate what you said about balance and using a dial. I'm concerned. I've done hospice and palliative for almost 40 years, and it seems like it's 1985 again. No way, no how can patients get pain medicines. Cancer patients even can't get pain relief unless they sign on to hospice. I remember in 85, we were a triplicate state, and at that time, less than 20% of physicians would order the triplicates. That meant that over 80% of docs wouldn't order Schedule IIs, no way, no how, to anybody. Mm-hmm. I'm afraid we're back there again. So I just want to speak up.
Thank you.
For the patients who have real pain and suffering, who are collateral damage in this crisis.
Yeah, absolutely true. And believe me, that was absolutely the point of view on the commission. I'll quote my dear friend Sean Mackey, who runs anesthesiology and pain medicine at Stanford. And I love what he said, which is, we should not be anti-opioid, we should not be pro-opioid, we should be pro-patient, which is exactly the right way to go. There's nothing wrong with opiates. Like I've worked in hospice care. They are magical for all kinds of things, not just in hospice care. They can bring relief to people we have no other way to help. And just as many people were harmed when we threw the switch crazily one direction, many people have been harmed with the switch crazily thrown the other direction. And there's a statement, it was organized by a friend at Stanford, Beth Darnell, and Sean, and I signed it, about this problem of non-consensual rapid tapers, which happened in a lot of states, just ruined people's lives. And even if you went back in time with a patient who'd, say, been on opioids for 10 or 20 years, and you thought, if I'd been there, I wouldn't have put them on opioids, like, maybe you wouldn't have, but you don't get to go back in time. They've been on them for a very long time. And not giving them their next prescription is not the same as not putting them on in the first place. And some people, you'll have to manage at high level opioids not because it's easy, because it's better than the alternatives. So thanks for bringing that up. You're absolutely right. Absolutely right. Okay, let's go on. These comments are fantastic. I really appreciate the engagement a lot. Let's talk about the criminal justice system. So, it's got, I've been doing drug policy related stuff forever. It is very clear we've had racialized enforcement against drugs. And many people are very cynical about the criminal justice system having any involvement at all, which I totally get. But there is a problem, though, with the idea that, let's say, why don't we just legalize recreational markets and nothing bad will happen? As you know, there's a lot of violence among Photoshop models. It's a tough community. But this is, with the broken glass alcohol. But we brought up in the paper, we just said, we need to just, let's think about this. What if we just said, it's legal, use whatever you want, wherever you want, and then criminal justice system wouldn't be involved. And alcohol really kind of blows that idea out of the water. It's the #1 drug in terms of arrest, violence, and incarceration. People do things when they're intoxicated that they wouldn't otherwise do. That's just the way the nature of drugs are. So there's no way to have the criminal justice system have no contact with people who are addicted, whether a drug is legal or not. So the way to think about it is, okay, there's gonna be contact. How do we stop it from being destructive and make it constructive as much as we can? And we had multiple suggestions about that. One is, given how many people in the criminal justice system are addicted, we need to be using their time inside as a rehabilitational opportunity. This is an utterly unradical thing to say. It is one of, most of the world would say, a core purpose of your correctional system is to help people, not just to discharge them exactly as they were or worse, but that opportunity is not taken advantage of. And I'll tell you more about things that are happening. We're having some movement on this front, I'm happy to say. But it's just ridiculous. I mean, someone sits there for 5 years. They could be treated. The marginal cost is minimal. You're already paying, they've got a place to live. They've got food. Why not give them some help? Second, to not put people in a cell because they're using opioids or they have a needle or they're carrying naloxone. All these things are happening. And we talk about that for multiple reasons. One of which is it's really dangerous. People go through withdrawal, which is horrible, usually. And I know in the movies you can get drugs easily in prison. It's actually hard. Most people can't get a regular supply of opioids in prison. So what happens is your body loses tolerance. Then you go out and you use your usual dose and you die. So now we've got, for possession, the penalty is not just jail, it's also hideous withdrawal and a high risk of death. Now, we don't punish treason in that way. I mean, this is just way out of control. So he said, let's just stop doing that. If the state or the community feels there needs to be some criminal justice response, make it ambulatory. Don't take away people's liberty. Maybe you mandate treatment, whatever. Maybe you write a ticket, but don't do that. Don't put them in a cell because they used an illicit opioid. And then last, I have to give Dr. Shelley Greenberg, who's one of our advisors, credit for this. Don't penalize substance use during pregnancy and treat it as a crime. There's a number of states that do this. They believe, if you put the strongest case you can, what they believe is they're going to get healthier babies this way. None of those states have good fetal outcomes. So instead of throwing someone again in jail because she used heroin while she was pregnant, what we should be doing is creating really high priority pathways to care. There's no amount of money you could spend on that work that wouldn't return the investment. You're utterly changing, that baby's life is going to be utterly different. So this is another thing we felt strongly about, and it's in the commission. Okay, and then we also want to talk about prevention. Substance use always occurs in an environment, and some environments are addictionogenic. One thing that happens, it's just how much drug is available. This is really a sort of dumb thing that people kind of forget, but just like if there's more bacteria in the water, more people get sick. If there's more guns in the community, more people get shot. When there's a heck of a lot of opioids around, more people use opioids. The excess even of surgery, just surgeries, is a couple billion pills every single year that are unused that just stack up in American medicine cabinets. If you went across all medicine, no one's ever done this. I mean, there'd just be a spectacular number of them. That is, I think about that kind of like guns. Like you wouldn't leave I hope you wouldn't, if you have a gun, you wouldn't leave it unlocked in your house if you have kids around. Same thing, we should not have houses where people just have bottles and bottles of opioids. And it's amazing, I mentioned this to a colleague, and I said, I have one bottle left over from a surgery, and I said, it's in the safe. And she said, I don't have any. Well, that's not true. I've got some Vicodin from when I broke my ankle. Well, actually, my husband has some. And then she went through and she realized she had 4 different opioid prescriptions, which she then went home to check to make sure they were still there because she has kids. So you need to pull that all out. And it's way too hard to do this. I mean, there are countries where you can just put them in the mail and send them back, or you can just give them back to your pharmacist, no big deal. And it's surprisingly hard to do that in the United States. Like if a pharmacy wants to have take-back, they have to have a special safe and special procedures and special licenses to do it. So we say this should just be like recycling. When you go into the pharmacy, every single one of them has to have a place where you just throw out your old ones and you get your new ones, just like we do with cans and bottles in the store. And we think the pharmaceutical industry should pay for it on the grounds that this is like pollution. If you pollute the environment in your company, you have to pay some relief for that. So let's say like when you go into the pharmacy, you get from Pfizer, whoever your drugs are from, here's $5 you can spend in the grocery store today. Like we did with bottles and cans. Those originally you got like 5 or 10 cents. In some states you do get something. Just till we make it a normative habit, and then it's something we don't think about. We need to pull those out of the environment. That's the most direct kind of thing. But there's also a more global thing, and I'm going to speculate a bit here and maybe get a little away from data. But I want to. Not everyone believes animal research, but this is my favorite piece of animal research of all time, and it's by Morgan and colleagues, and it's of macaques. So not humans, but we're related to macaques. They're primates. And in this study, this is I think it's at the NIMH compound. They let macaques. The macaques were separate. They gave them access to cocaine. They measured how much cocaine they used, and they also gave them an MRI. Then they open up the doors of the cage, and the primates will go into the center. They're primates, so they form a hierarchy. The big primates push around the little primates. The bigger macaques get more food. The weaker macaques are like having to groom the powerful macaques. Those of you who are in grad school will resonate with this kind of experience. Appease them and all that so they don't get pushed around. And then they give them cocaine again. What happens? The ones at the top don't use any more cocaine, but the ones in the bottom do. Now, these are the same macaques who used X, and now they're using 2X. What's different in their life? They're on the bottom of a hierarchy. Also interesting, the ones at the top have upregulated D2 receptors, as if they were getting reward. Well, it's good to be the king, right? Much better to be on top than the bottom. Okay, so I know those are animals, they're not people, and I know it's an experiment. But I don't think it's that much of a stretch to think that human reward could have a similar kind of structure. If you're on the bottom, however you think about that drugs would be more attractive than if you're on the top, in whatever situation you might be in. Oh, and I just want one other thing. Some people misunderstood this point when the commission came out, that this just means money. It actually doesn't just mean money. Again, like I said, it's not that simple that if you have money, you don't use drugs. In fact, if you look worldwide, actually, rich countries have more drug problems. It's about stress, it's about lack of opportunity, it's about lack of competing rewards, and sometimes you can be poor and have a lot of a rich, wonderful community, you can be rich and not good. So it's more complicated than just simple money. So what would we do? Well, first off, we would really raise the quality of these excess opioid disposal programs. Second, we talk about prevention. I think DARE left us with a bad taste in our mouth about prevention because it didn't work and it was so widely used. But actually, first off, it's been revised twice and it does work a bit. But we have even better programs than that, like communities that care. And what's cool about them is that the same risk factors that make it likely that a kid's going to have a drug problem are the same things generally that make it likely that he or she will drop out of school or be bullied or get depressed or do self-harm or have an eating disorder. So we could focus on those core strengths, those core capacities kids need, things like being able to recognize and manage your feelings, things like being able to connect with other people. That's where we should make our prevention investment, particularly for low-income kids, but for all kids could use those things. And then last, we point out this is always true about drug policy, there are programs that have nothing to do about drugs that in fact help with our drug problem. Like nurse-family partnership, if you know that program, where it's low-income, pregnant women, nurses come out and visit them, teach them about prenatal care, and kind of help them through the first months. Those studies now have been followed out to like 20 years. And those kids' lives are dramatically better. And these are randomized studies, by the way. And they're more likely to finish school, they have higher income, they're less likely to be depressed, and they use less drugs, even though there is no drug content in that program. It's just about getting people a healthy start in life. So we can make investments like that. We talk about early childhood education, other kinds of things. When the brain is highly plastic, when people really need support. If we made those investments, I think we should make them anyway, because we don't do enough for kids, in my opinion. But in terms of just opiates, it would help with our addiction problem too. So it's like extra bonus points for helping kids. Now I'll talk about innovation, and I'll say something depressing. So I started my career here in Michigan. My job was, I worked at the Department of Psychiatry at Michigan State University, and we had a contract from the state to evaluate whether treatment worked. So I went to probably almost every public addiction treatment program in the state at some point. So the most depressing thing about my career is now, 37 years later, those places largely look exactly the way they did 37 years ago. That's not true of cardiology, it's not true in oncology. If you did what cardiologists did 37 years ago, you would be deservedly fired from Stanford Hospital, because there's been so much improvement in care. It's so much better. It's amazing how little has changed in the addiction field. It's really, really disappointing to me. We don't have a lot of new treatments. The things we have don't work dramatically better. We don't have many big breakthroughs. So we just thought about this as a problem about, what is it we're not innovating? And by the way, this is also true on the law enforcement supply control side, doing a lot of things that don't work well over and over and over again. How do you get to a spirit of innovation? And this was a really fun thing to talk about. It's a little ephemeral, but everyone on commission was so smart. I love their sort of creativity about where do you inject that? Where does that come from? And I had a number of ideas about that. One of them was to create something like DARPA. If you know what DARPA is, it's the defense, actually I don't even know what it stands for. It's basically really creative people who have off-the-wall ideas, and they work in the Defense Department, and they invented like the internet and things like that. So we need a DARPA for health, of people who know nothing about opioids, nothing about addiction, and just come in and say, all right, here's something you haven't thought of. And actually now we have one. There's actually just been one created at HHS, which is really great. We also thought we need to really change the epidemiology. We're still calling people up on the phone and saying, hi, this is the federal government. Do you use drugs? Great, good. Glad you don't. And you commit any crime? Good, great. No crime? Awesome. You have a great day. That's what we do. That's what the National Survey of Drug Use Health. It's not quite that bad, but it's pretty bad. We know very well that heroin use is at least 10 times higher than what you get out of those surveys, at least. We know that from deaths. We know that from all the traffic. It's amazing. Why is anyone shipping heroin to the United States when nobody uses it, according to our surveys? A lot of people use it. There have to be users to explain all these people shipping in heroin. So there's a lot of stuff we could do creatively with epidemiology, like, for example, wastewater technology, which is used in every other developed country a lot, other than us. We just started using it for COVID. You can find all kinds of interesting things out from wastewater. For example, one of the things that happened in the UK, which is really interesting, is a friend of mine was running the prison system in the UK, and he said during COVID, when they cut off visitation, they looked at wastewater and there was no change to drug use levels in prison, which means that it's not visitors bringing drugs into prisons, it's the staff. That's a really important thing you can only figure out through wastewater epidemiology. You can figure out lots of other things, like what are the new drugs? What are people using? Because they may not even know what they're using. I think we need to use these devices we carry around in our pocket much more too. There's all kinds of things we could learn about global positioning, how people talk, analyzing Twitter and Instagram and all these other things to pick up on drug trends early, for example. Often like Reddit is the place to go to find out about new drug threats, way before they show up in CDC data. People who use drugs are telling you, hey, there's this new thing, it's like this, it does that and that. We should be doing all that stuff. And I'm encouraged, actually, some groups are working on that. I also talked about redesigning the opioid molecule. There are very different views of whether this is possible. In fact, I gave this talk, and someone said, that is impossible, I'm sure. And Brian Kabilka at Stanford says it is possible. And Brian has a Nobel, so I'm going to go with that and be optimistic. But the point is that opioids have multiple effects in the brain that may not have to be linked. There's sort of three things it does: kills your pain, you feel euphoric, and your system slows down, including your breathing. That's why you die. In animals, those are already been separated in several experiments. In other words, you have an opioid that will kill pain but not stop breathing. Wouldn't it be awesome to have something like that? Then nobody would die of an overdose from a prescribed pill. It'd be magical. And also, we need to get out of just looking at opioids for pain and look at other kinds of medications, new development. And there's we talk about what NIH could do to get us some non-opioid pain medications more. We have some now, but to get more ones and better ones. We also need to weigh international data more. There are lots of treatments on the pharma side that are used in countries with good healthcare systems, and we don't have them because it was too much of a pain for a company to get them approved, like slow-release oral morphine or injected hydromorphone. These are used in places like Australia, Canada, Europe. But if you wanted to bring them to the United States and give patients more options, they would treat it like they barely weigh the international data. They give lip service to it, they look at it, but you would have to run all the trials all over again. We don't have time to do that, and we don't need to do that. These medications have been used for years safely. We should just start using them. And then also on the supply side, it's very hard. A lot of us in this field are kind of just, despairing that we can do anything about the supply of fentanyl, but we do at least cite some interesting technologies that have been used, rapid scanning, sort of based on like something like a PET scan that can just spray a truck for a second and tell if there's any fentanyl inside. So we say maybe we could do more of that. We didn't really know. That was a tough one. It's tough to stop fentanyl. Okay, I'm going to pause there again. I've gone through a couple other domains and see if you have any comments before we move into looking at global issues. Right there.
I want to go back to your point about looking at international data and at your point earlier when you did the comparison. direction to a doctor and be told. I mean, kids typically don't get antibiotics with ear infections, with sore throats, all these things. And I think the part that's kind of missing is, I agree with you, we should look more at the international data, what to do. That you didn't mention is talk therapy in some way. I think human interaction with doctor and it's every psychiatry department will tell you that they lose money on every interaction where people are counseled. New Jersey, my brother is right now in a spa treatment for 4 weeks, paid by health insurance, where all he's getting is basically. I think there is a much, much bigger issue of no matter what the companies can charge whatever they want, and there's no way for us to say, no, we're not going to pay this amount. Not because it's
Good. Okay, so very, very good point. And we do deal with that in the commission. I mean, you're absolutely right that you have to look at the economics of this. So one of the things we pointed out is where did why was the problem so bad for First Nations peoples in Canada? It's because the model was doctors flew in literally for a week, and they would just see everybody once. What can you do when a huge amount of human suffering comes in? You have 20 minutes at most with each person to fix it, and you'll never see them again. There's really only one thing you can do: you get out the pad and you write a prescription. Physical therapy is not reimbursed. Mental health care is not reimbursed, and that's part of the problem. I also want to say something else about Germany that is really interesting. I'm working now with some German pain experts. Germany prescribes, by international standards, actually more opioids than most countries, but they don't have an opioid crisis. And one of the interesting things about them is we're trying to figure out, why is that so? Because at this point, they're almost as high as Canada. And a big difference is that most of the opioid prescribing is monitored. So there's a lot of prescribing in hospitals and in nursing homes and in hospice cares, but there's not a lot of ambulatory prescription. You're about 4 times more likely in Canada to be handed a bottle of pills and sent on in the community. And that really changes the society's risk once you start doing that, because you never know where they're going to go. And that's sort of very interesting. Last point, we also talked just about the role of culture and how, if you watch TV in America, I mean, what are you told? Basically, every human problem can be solved by a pill. Ask your doctor about that. And even though you don't see opioid ads, it is a message. Doctors give pills. If you have a problem, ask your doctor for a pill. And if your doctor doesn't give it to you, that's a bad doctor. I tell this my French colleagues, they just laugh. I go to a doctor now and say, I'm 57, I ran a marathon, I hurt all over, fix me. My doctor will scramble around trying to fix me. So a French doctor would say, c'est la vie, have a glass of wine, life's tough. I wouldn't do that if I were you, and just, don't run like that, and the end. And it's just not that expectation that there will be a solution to everything, first off, and second, that it will be a pharmacological solution. And that is really hard to get out, but that cultural expectation I don't think is very good for us, particularly because a lot of the basic, aging, decline, death, it's part of life. We can't get rid of that. So a little more messaging about just the reality of the limits. Medicine can do a lot, but it can't make life perfect. Yeah, there are 2 questions there. We'll take them both.
Thank you for your comments about the criminal justice system, because I had a friend that was exactly what you described. Was picked up for marijuana before it was recreationally legal here, and was incarcerated, and then when he came home, went back on Oxy and died.
That's horrible. I'm sorry.
And so my question is, has your research or data shown any intersection between the legalization of cannabis across our country in many states and a potential increase in opioid use?
Yeah, what a great question. So there were some correlational studies early on that showed as medical cannabis spread and then recreational cannabis, opioid overdoses went down. But this was a state-level correlation. Lots of things correlate at the state level that don't correlate at the individual level. States with serve more ice cream have higher rates of drowning because there's oceans. That's why people eat ice cream on the beach. And the industry put this on billboards. Legalize cannabis and the opioid overdoses will drop by 50%. This is the solution. Well, Chelsea Shover, who was on the commission, went back using the same statistical code and adding 7 years more data that had been available since that first study, and actually the correlation has now going the other direction, with it being positive. She didn't think that's causal any more than the first one was, but it just shows how fragile and oversold that finding was. Cannabis use is just going up and up and up and up, and heavy use is going up and up. And if you look at THC consumption, it's going up even faster in parallel with the opioid crisis. So if cannabis use is going to stop the opioid crisis, it sure is taking its time, because we're having an awful lot of cannabis use, and we're still having a terrible opioid crisis. So that, I don't think, is the solution. Right in front of you is another question.
So my question was, thank you, was relating to the innovation piece that you were talking about. I'm a computer scientist. I work in AI. The same technology that we have that allows us to have like these targeted ads, all these things, that exists. Like we can build the same technology to predict who is more likely to suffer from substance use disorder. The challenge is the data, because I'm not Google, right? I don't own everybody's data. You just hit a roadblock when you start thinking of like the data that I need to create a predictor like that basically requires mass surveillance. So I was curious to hear if you know of any initiatives that make data more available in order to kind of build these innovations.
Yeah, so we actually have been working with Google and Facebook and that kind of thing to talk about this kind of stuff. We don't have their data yet, but they do have a public good, initiatives that they just fund off their enormous profits. And this is one of the things they're interested in. There's also multiple groups working on other social media, because people do put all kinds of information, whether they know it or not, in their social media about their mood, how often they're sending stuff out, whether it's complicated or simple or emotional and that kind of thing, all of which you could use to do epidemiology. You could also use some of these technologies to help people in treatment if they consent to it. So a colleague of mine told me about a company that, the person has to consent, but if they consent, they say, enter your places where you score your drugs, and let us know where they are, and then the GPS will track. And so they'll say, Keith, I noticed you're walking towards that park where you buy heroin. Would you like to talk to a drug counselor right now? So that's brilliant, just as you can use these technologies to make addictions worse, but there's also this chance to intervene and do it better. So there is work going on in that area. That's great. Let me move to international, and then I will be done. So if you've probably heard someone say at some point in your life, we've won the war on smoking. And if I look around this room, it does look like we've won the war on smoking. But if that's winning, we certainly smoke a lot less than we used to as a country. But on the other hand, if you consider that when developed nations cracked down on tobacco, the companies went to India and Brazil and China and caused billions of deaths they're going to let people die over the century, you would realize we didn't really win the war on smoking. We exported smoking, but we beat it here. But a lot of people are still suffering in poor countries. And now we're at risk for the precise same thing to happen with opioids. And I had to rely on journalism to get a lot of this data. It's not something that's been studied a lot, but there are a lot of pieces when you start looking. This is some really nice work that was in the British newspaper The Guardian about the arrival of for-profit companies in India, very similar to the United States, poorly regulated, potent opioids being distributed, very profit-driven, without much consideration for patient benefit. This was an amazing story from China, where pharmaceutical promotion people were actually putting on white coats and stethoscopes and impersonating doctors and walking around hospitals, talking to patients and talking to staff about how great opioids are. One of the creepy things is that this is the same people who made the Purdue Pharma. So the Sackler family owns Purdue Pharma. Purdue Pharma is going to be closed under the terms of the lawsuit, but the family is untouched. And they have the right to sell OxyContin in other parts of the world, and they are. And all the agreements they've made about not doing sleazy things don't apply outside the United States. So we're seeing this just happening all over again. This is a quote. It was a great series in the LA Times that was from some of the released material. And it was this quote, we're only just getting started. And this shows all the places where OxyContin is being promoted by originally Purdue Pharma and now by Mundi Pharma, which is the Sacklers, one of the Sacklers' other companies. But we're seeing everything we saw before. Covert payoffs, fake patient groups, underselling the risks, all of that. Here's Italy. There's again Mundi Pharma. Paid promotions, big corruption scandal, bribery, every gross thing that we saw here. And you know what? It's working for them. I picked these nations, could have picked any, but you can just see up and up and up and up for opioid prescribing. And it just keeps happening. And you're seeing, like, I think Australia had 15-fold increase of prescribing of opioids. And then you're starting to see then hospitalizations for opioid overdose, deaths from opioid overdose going up in tandem. So one point of view would be, well, we just need to solve our own problem. The rest of the world is not our business. But I think we should be a good global citizen and not just export our terrible decisions worldwide or let American companies do terrible things as long as they're not happening here. So I've been trying as hard as I can. It is not easy, in international fora, to make people aware of this and not to tell themselves, which is what a lot of them do. Like after this came out, I did some talks like in Europe and things, and they say, well, that's just America. Only America could have an opioid crisis. It's just something about your country. It's like, first off, that's not even true now. Canada has one. Canada is not America, but now Norway's having more deaths, and the Netherlands are having more deaths. And so now they're saying, well, yeah, a lot of people are dying, but it's not as bad as America. It's like, good grief, don't make us the standard. You want to do way better than us on this thing. So we really worry about that. And, again, to return to the principle of balance, there are other places that have the opposite problem. So if you are in Malawi or Kerala, India, where I gave a talk about this recently, you probably don't have any access to opioids at all, and hardly a single doctor would prescribe them. Some doctors have never seen an opioid. So people are in agony because they don't have any opioids. And we're all in the same boat on this because opioids are controlled by United Nations treaties that something like 195 countries have signed. So there's this pressure internationally by the countries that are getting crushed by opioids, or like we were, to say, okay, let's really clamp down. But you have to remember, but there's other places where their problem is they don't have any access at all. Not that they have too many, they don't have any, or they have very, very, very few. So we were trying to grapple with this. How do you do this? Something more humane than, well, let's just count on the Sackler family to sort this out. And we read a different commission's report, the Lancet Commission on Palliative Care and Pain Relief, and they said, morphine is cheap, generic morphine is cheap. Why don't donor nations just pay for it and have WHO provide it to low-income nations? That would give you pain relief without the profit motive that could be so destructive. And it's not that expensive. So we endorsed that idea. We focused on hospitals and hospices. We thought that would be, a safe place to start, certainly very needed. But that's something, so I've been, since then, working with that Lancet Commission and working with the UN on trying to make this happen. And the goal is, this is a wonderful phrase, access without excess. That's what we want. You can have too many, but you can also have too few. Okay, so what actually happened when this came out? It did make a splash, I'm happy to say, worldwide headlines and news company coverage, a lot of stuff in the US. We had a lot of government interest, did multiple briefings at the White House, for HHS Secretary's office, for members of Congress. I actually got to go to number 10 Downing Street and give a briefing there, which was a lot of fun. I've done a lot of work with NGOs because this is it's just a document. 17 people can't change the world, but like other groups that work in this area to try to get connections, make this happen, including the Lancet Commission on Palliative Care and Pain Relief, and now a third Lancet Commission on the value of death, which we're trying to do some stuff on pain together. Let me close on an upbeat note. Some very good things have happened, and these are things we recommended, but you'd have to be kind of delusional to say, and because we published a journal article, the world changed, but it's more maybe we were one of 10,000 inputs into these things, and just happy they happened. So one is that the Department of Labor has really started enforcing the parity rules that they're supposed to protect all of us so that our insurance covers addiction care. There's been more enforcement than ever in the last couple of years. That's really good. That'll increase access to care. Second, we've had expansions of access to buprenorphine treatment. So there used to be something called the X waiver, which was a barrier to people being able to prescribe. That is now gone. Even more importantly, that there's a universal training requirement, which is something we recommended in the commission, meaning, I mean, the way it was before, it was sort of strange. It's like if you're going to treat addicted patients, you need special training in addiction, but if you're going to prescribe addictive drugs, you don't need any. So that's going to change. So when you get your license from the DEA, if you prescribe controlled license, you will have to know something about addiction, which you really should. I mean, not that you have to become an addiction specialist, but if you're going to write prescriptions for, benzodiazepines and Vicodin, you should know that they're addictive, know how to prescribe in a way that lowers the risk, and also how to notice when your patient is addicted or starting to become addicted. There's been some improvements in epidemiology. The White House has stood up the first system we've ever had measuring non-fatal overdoses. There's a lot of interesting work going on in like using social media to try to find out more. There's finally some interest in wastewater. I think we can perhaps ride on the interest that COVID created in that if we can get CDC on board with that. And I mentioned the FDA and senior officials saying, yeah, we should do this differently, and they did circulate a discussion draft. That's good. The UN work has gone pretty well, I think. We got some big meetings this summer. We'll see how it goes. But we've been trying to deal with this problem, us being like addiction people like me, but also palliative care, pain relief people from these other Lancet commissions and other experts about how do you make a treaty arrangement such that nobody has too much, but nobody has too little. And what do you do to help nations that need more opioids, not fewer opioids? Prison treatment, I'm really pleased at what's gone on. So the First Step Act was passed in 2018, said that the federal prison system will provide addiction treatment to anybody who needs it. And that was in the Trump administration. President Biden in the State of the Union this January repeated that and said this will be done by this summer. Now, the federal prison system is only 11% of the prison system, but nonetheless, that's great. And I'm really happy that in California, led by Assembly member Marie Waldron, and we worked with her closely on this, is going to be the first state in the country to be able to use Medicaid to pay for addiction and mental health care while people are in prison. Medicaid has a thing in it with the federal government says we won't pay for that. So we applied, we had to do a bill in the legislature, it passed, and then we had to ask for a waiver, and we got it. So starting next year, when you are about to leave a correctional facility, your Medicaid will turn back on, and then you can give people care during that transition, which is an incredibly vulnerable time. And I'm really happy, right after we got that done in California, the federal government said, look what California is doing, the rest of you states, and apply for waivers too. So that's really exciting, because the places that have done this using their own money have saved an awful lot of lives. And last, it's interesting, we recommended a DARPA-like thing, and now actually one is being created at NIH to be really creative. We'll see what happens, but I think that's good, and I hope they will devote some time to the opioid crisis, particularly people who don't have any background in it and just come up with an off-the-wall idea. Some of them will be stupid, but who knows, maybe something will be much better than anything those of us who've been looking at it for too long could think of. So this is the website. It's still up, opioids.stanford.edu. You can see all the publications, all the coverage, every member, all their disclosures, and our recommendations in sort of a broken down, simple, easy to access form. It's all there, and I hope you will take a look at it. Thanks very much. Sit there.
All right. Well, thank you, Dr. Humphreys, and thank you, Dr. Bonnert. Just a couple of quick notes, and then I'll take the lights out of your eyes. So I'm Chad Brummett, anesthesiologist, pain physician, and one of the other co-directors of the Opioid Research Institute. We're going to have a Q&A session now, and we've actually got some Q&A from online that we'll go through as well. So we've been getting some questions, and then we'll have a chance to go. I know it's about 11:52. We might go over a few minutes. We certainly understand if people have to go throughout that time. So I'm going to take the lights out of your eyes. And I think one of the questions we got a few times online is, and we talked about this at dinner last night, is that intersection of pain and opioid use, but also pain, substance use disorder, and opioid use. And I had just left clinic that day where I had dealt with that actually more times than I typically do in a pain clinic. Talk about how the commission took into account the voices of people with pain, those with substance use disorders, and any intersection of those, and kind of those recommendations and how those played into the recommendations either from the Lancet Commission or what you're doing now.
Yeah, so as I said, there were people on the commission who had experienced chronic pain. We also were really lucky to have Sean Mackey, who's a national leader in pain medicine. And all of us just had a huge amount of interchange with many, many people once the commission came. I got, emails from people I didn't know all the time. People called me, people sent letters, things like that. So we had original plan was to have actually some meetings like this. But our first meeting, as you know, was 2 weeks before COVID came in. So that kind of collapsed that. And that gave us less chance for structured input than we wanted, but there was still a huge amount. And the discussion goes on. It's a commission report. Commissions update the reports over time. I looked, this thing's already been cited over 100 times. There are, people are writing comments, they're debating it. That's terrific. And, we'll learn from that too.
Yeah. Dr. Bonner, I have a question for you that I think Dr. Humphreys will also find interesting given your West Virginia roots, but Michigan has a large rural population. And I'd love it if you could sort of talk about how the Michigan Opioid Collaborative thought about the unique challenges of an urban population versus a rural population, and how you thought about increasing capacity for substance use disorder treatment in places with low access to care and treatment. And I'll also give a shout out within the MOC to Dr. Allison Lynn in the Department of Psychiatry, who was critical in helping bring this forward.
Yeah, thank you for that question, Chet. Is this picking up okay? I can just project. Okay, so I will say actually a fundamental problem when it comes to translating research on addiction to practice, to the real world, is that the vast majority of research on this topic has been done in coastal cities. So a lot of the models of care don't necessarily apply well. Thank you. A lot of the models of care that were developed, the way these medications were tested, the structures around them, work really poorly when you're in the Upper Peninsula and, getting to the closest pharmacy is 2 hours away, let's say, right? And then on top of that, we have issues of pharmacies that won't stock buprenorphine or will only dispense it to patients if they have a personal relationship with the doctor who wrote the prescription. So, I think fundamentally I want to advocate for needing more research that studies models of care in rural areas. That being said, with MOC, we don't have time to wait for that research to be done. So I see Joanna in the back. We have behavioral health consultants who are situated in the parts of the state, in the communities they're in, who learn who's doing work that is working in that area. And then we take this learning collaborative approach that transfers knowledge from people who have figured out how to set up a clinic that is meeting the needs of their patients and helps other clinicians in that same area learn from that process. So that's been a big piece. There's been working with the pharmacy. So rather than leaving it to the physicians to figure out what pharmacies to recommend their patients to go to, we take on that legwork of reaching out to the pharmacies, trying to overcome their stigma barriers related to buprenorphine. Certainly supporting telehealth models, which, in some cases is the only option people will have. I think that's a really important part of rural that we've also tried to support in MOC.
Great. Dr. Humphreys, any other comments about the rural population?
No, as usual, incredibly well said. So I'm just going to agree.
Questions from the audience? Yeah. You have a microphone, or I can repeat it. Mario.
By the way, thank you for coming. And let's assume that all the domains are executed upon and, we move forward. What can be done at universities like this one and yours to encourage more people to pursue this as a profession? Because we're going to be overwhelmed with people who need care. And if it's going to be hurry up and take a number, we're not going to make much progress. And so, in your opinion, how do we get more people to say, I want to become an addiction psychiatrist or an epidemiologist or a therapist?
Yeah. So we do talk about that in the report. And just tell you sort of interesting thing. Do you know there were no geriatricians, no geriatric medical fellowships until 1966, and it's because Medicare was passed just before, creating tens of millions of customers. Like it or not, that's how our system works. When people are insured for things that are reimbursed, more people go into that as for careers. People aren't stupid. They need to have an income. So the insurance reforms we talk about on both the public and the private side would make more people, customers, people who would bring revenue into places like Michigan, places like Stanford, and everywhere else. And that would stimulate more people to make their career about addiction. We don't have the idea that the only person who can handle this are addiction specialists. So that's why we say, everyone else has to do stuff too. So, for example, getting rid of an X waiver so any doctor can be a buprenorphine prescriber, making sure every doctors get at least some training in addiction, improving the quality of medical education. Years ago, I used to say at Stanford, I am confident that the addiction education our medical students get is lousy because I know I do it all myself. Like I show up for like 1 hour. There's this condition called addiction. It's really rare. You probably never see it, but I'll just tell you what it is. Of course, you can't do a single day's practice in any special without running into something that's connected to addiction. So improving that, and at the same time, doing it in the relationship with pharma, keeping some clear blue water there. Because one of the problems is some of the education that was given at some places, not Stanford, I'm proud to say, but some places was really corrupted by the industry. So it's okay to work with industry, it's okay to take money from industry, but it has to be thrown over the fence with no control of what is actually said. Otherwise, then we just become another arm of the industry, and we're not going to prepare our students adequately.
I agree with all that, Nod. One idea, I had the opportunity to review evaluation data from a program that MDCHS piloted of loan repayment for physicians who went into addiction. Really successful outcomes from what I could see from that. And I know they're looking to expand it. I think also doing it for other types of healthcare professionals would be really good.
I think that is a positive place to sort of leave things. I want to just thank everybody for coming, and I want to give special thanks to our event co-sponsor, the IHPI, the Institute for Healthcare Policy and Innovation, and Dr. Ayanian. I don't think he was here a second ago. I know he had another meeting. The team at OVPR, Open and Government Relations for throwing in all the support. Special thanks to Abby Hall and Wendy Mole for coordinating today's event. I really appreciate all your help. None of this happens without incredible people. Again, the Opioid Research Institute, I think we're parting into our third week here, so we're brand new, but encourage you to go to opioids.umich.edu. Many of you have your own content, your own programs on there. We want to continue to connect and promote and do bigger and better work here at the University of Michigan. As Dr. Humphreys clearly denoted, this is an all hands on deck situation, and we really need to be present. So thank you very much. Thanks.